Hi, my name is Davina DeBoll. I'm an RN to BSN student at Columbus State University doing the senior project. I have with me Erica.
Hi.
And Joanna. Here to see the presentation on reducing verbal orders and evidence-based approach. So, what's this all about? I'm not going to read y'all that abstract. You can read it yourselves. Basically, we are a 104-bed hospital. 98 of those are residential beds. 16 of those are acute beds. And currently, we are running at about 90% verbal order rate. Overall orders. And so, with that, we're getting a lot of medication errors. Most of them are missed doses. Some of them are wrong time. Some of them are wrong dose. This presentation is going to explain why that's a problem, obviously, and what changes can be made to improve that, as well as information on the EMAR that is actually coming to Laurel Heights Hospital. So, one case study I observed, now I did do random observations of charts and came up with that 90% rate from random observations. However, one case study, a patient had not received a medication in 2 weeks due to a medication error that's root cause was essentially a verbal order. A physician had called in multiple verbal orders to one nurse. All except this order got put into the physician order forms. This one was not put into the physician order form. However, the first part of the order was put on the MAR to stop that dose, but the second part to start a new dose never got put on the MAR, never got put on an order, and so the child went without medication for 2 weeks. So the root cause of that was that the physician did not write their order. They used a verbal order because they were on site when that occurred. Another case study, a wrong dose error. We had new admission come in. There was no physician on site for this one. However, the nurse, when they called it in, the patient was on 0.05 milligrams of clonidine. And as she was getting verbal orders, was not writing down the orders. So once she did decide to transcribe the orders onto an order sheet and onto the MAR, the dose that was written down was 0.5 milligrams as opposed to 0.05. And then nurses subsequently documented multiple times that they had given 0.5 milligrams. So again, the root cause of that would be a faulty process with verbal orders because there's no guideline streamlined process. So interdepartmentally, everybody is involved in this. The physicians not being willing to walk across the street from their offices to the campus to write the orders, being resistant to writing them even when they're right next to the chart. Nurses not feeling empowered to request the doctor to write their own order and stand behind that decision. Not following a pathway for verbal orders. And at the bottom is just the high rate of verbal orders in general. So the expected benefits of reducing verbal orders for patients is obviously improve patient safety, because if you reduce verbal orders, you're going to reduce the risk or either potential or realized risk of medication errors occurring. For physicians or for nurses, we won't be pulled away from other nursing tasks, including medication administration, which has happened, to answer the phone and take a verbal order. We'll also feel more empowered and have more of a voice interdepartmentally. Physicians will know that their orders are being accurately written down, and that their medication management regime, they'll be more aware of what it is because they'll be the ones writing it consistently. So increased risk. There is this study by Didifo, Matiki, and Angamo that was published in 2016 on rates of medication errors in a specific hospital. And they were looking at what increased the rate for medication errors. And a lot of the root causes for medication errors are present in our hospital. A longer length of stay. We have residential kids. We have some kids that have been here 4 years. Increased number of medications. We have some kids that are on, I promise you, it seems like 20 different medications in a day. Multiple diagnoses. All of our kids are here with multiple psychiatric and some of them with multiple medical diagnoses. And high volume of verbal orders, which of course at 90% we are running at an extremely high volume. So mitigating risk. The Joint Commission, National Coordinating Council for Medication Error Reporting and Prevention, as well as Centers for Medicare and Medicaid Services, all recognize that verbal orders are a high-risk area for medication errors to occur. And the Joint Commission and Centers for Medicare and Medicaid Services both recommend reduction in verbal orders and only using them for emergency purposes. Given the residential nature of 98 beds, a reduction in verbal orders to less than 20% of total overall orders is realistic. For our acute unit, less than 50% would be a good goal to set initially. 3 interventions that can help reach this goal and possibly surpass it. Limiting verbal orders to emergency services only, which include things like if they need first aid treatment that's not already written into one of our PRN order sets. If they have to go to the emergency room, x-rays for a trauma that occurs when the physician is not on site. Strict guidelines should be followed by physicians and nurses when verbal orders are warranted. And then we do have a new development in the facility. We are preparing to have an electronic MAR installed with various features, which should also help us reach and or surpass this goal. So sound-alike, look-alike drugs, if we're going to take verbal orders, these are the guidelines. Sound-alike, look-alike drugs should be spelled out letter by letter to prevent miscommunication. Medication doses should be said number by number versus a whole, like instead of saying 150, which can be 150 or 115, we should say 150 milligrams or whatever it is. So we're clear on that. Specific times, so 7 a.m., 12 noon, 3 p.m., 7 p.m., those are our general times here. Whatever is pertinent to your facility. As opposed to saying BID, because BID could be 7 or 12, 7 and 12, 12 and 3, TID, etc., etc. Only licensed nursing staff are to be taking verbal orders. A staff member cannot walk up and say, hey, Dr. So-and-so said, put so-and-so on these precautions. That's not acceptable. And then when it's apparent a verbal order is going to be given, nursing is going to obtain a physician order sheet and transcribe the order as it's given versus hearing it, stating it back, and then writing it down. So we're going to write it down, verify it with the physician while we're on the phone, and then we're going to initial off that it has been read back and verified. So departmental responsibilities, this is really medical and nursing. So medical would be the physicians, nursing is obviously our nurses. Medical, they need to physically write orders for the majority of their orders, including routine medications, therapeutically used, rec therapy outings, anything that's going off campus that's known about prior to them leaving the facility. Labs that they would like ordered, those kind of routine care items. Again, those emergency uses that we spoke of before, those can be done verbally. Nursing is to receive a verbal order when it's appropriate, to encourage the physicians to write their own orders when they're on site, to provide them with a physician order sheet even if they need one, and monitor the patient's responses to medications and treatment, report to the physician any changes as necessary, and carry out physician orders appropriately. So timeline for actualization, meetings have been held about this and about needing the policy for the verbal orders and those things behind the scenes with management. So now we're actually at where we would implement this on May 1st, which is not this Monday, but next Monday. So the new policy would go into effect, and then within June, the first review would happen about what's going well, what improvements can be made, and then a follow-up review in July after improvements are made as warranted, and see where we are then. So it's coming. An EMAR is coming to us finally within the next 6 months. There was a meeting in March with upper management, and then myself, I'm not upper, I'm middle management, but to discuss nursing and medical and how we're going to all work with that. The company that owns the software has already heard what we need from them. So the EMAR will include the ability for computerized physician order entry, including medications as well as other treatment measures, so that should reduce our verbal orders. Access to pharmaceutical history for up to a year for our kids as long as the pharmacy is linked to their system. Medication reconciliation at various points, so at any time you can go in and reconcile medication so that we see what's really going on with this kid. And then we're also going to include the patient photograph onto the EMR so that we have that second patient identifier right there on the screen and available to us. Corporate's also been out here to examine our environment and our layout and see what we need hardware-wise to facilitate this. So we're there. So personal responsibility in all of this, as well as other changes that occur as a manager. It's my responsibility to participate in meetings leading up to a policy change, if it affects nursing or if nursing is involved with multiple departments. It's my responsibility to assist with policy generation, review, and or revision. It's my responsibility to disseminate the information to departmental staff and clarify any questions as they arise. It's my responsibility to role model the expectation and make corrections as needed, and to empower you guys to be able to carry out any changes that occur. And how will this affect me personally? It's helped me clarify my role. And any improvement, so with the EMR on here, it says with the EMR, I'm going to probably be a super user, which is a new skill that will be learned. And again, any new skill, new information that comes up, provide you with more information to be a better nurse. So that is the presentation on reducing verbal orders and why it would be beneficial. Any questions while we're still rolling? No?
Got it.
Did we clap?
You can clap. Thanks.